Alright, we are back with hypoxia and hypoxemia. Okay, these two concepts, I know I say this for everything, but these two concepts are very, very important. So it's important to understand the concepts here. Okay, so just for a big picture concept, so the total O2 content of the blood includes bound and dissolved is the total amount of oxygen carried in the blood, and it depends, as you can imagine, mostly on hemoglobin concentration, but also on oxygen binding capacity of hemoglobin, the partial pressure of oxygen, and the P50 of hemoglobin, which we talked about yesterday or the other day. And as you can imagine, hemoglobin. So the formula is heavily dependent on hemoglobin. Okay, so hypoxia is decreased tissue oxygenation. You can also think of this as decreased organ perfusion, like decreased oxygen delivery to the tissues. Hypoxemia, the EAM, should remind you that it is decreased arterial oxygen, and it's defined by less than 60 millimeters of mercury for like the PaO2, and the oxygen saturation, which is dependent upon the PaO2, is less than 90%. So that's the definition of hypoxemia. We're going to start off first talking about hypoxia. And as I mentioned, it might be easier to think of this as decreased organ perfusion, right? Whoops. Okay. So this is your organ. This is the arterial side and venous side. So hypoxia can be caused by ischemia, which can be caused by three big picture things. One is an arterial, well, first you can have atherosclerosis of an artery. You can have a clot, right, that blocks off the blood flow to the tissue. But you can also have a venous clot. These are pretty rare, but there are things that can cause venous clots. There are inherited conditions that cause a hypercoagulable state. There are things like polycythemia vera, which increases the viscosity of the blood, the thickness so much that it can cause venous clots. And so the mechanism of this is, basically, if you're blocking the venous side, you're preventing fresh blood from flowing into the organ, because there's going to be a backflow, right? Because this blood can't get out, so you're not able to bring fresh oxygenated blood into the organ. And then shock is really, really common cause of death in hospitals. Can be caused by infection. Can be caused by blood loss, hypovolemic shock. There's cardiogenic shock. There's neurogenic shock. I won't go into the mechanism there, but those are the big three causes of ischemia, which cause hypoxia. Hypoxemia will inevitably lead to hypoxia if it's not taken care of. And remember, that's the decreased arterial oxygen. And decreased oxygen carrying capacity of the blood can also lead to hypoxia. And the three big causes of that all have to do with red blood cell stuff and hemoglobin stuff. So anemia, you have decreased red blood cell mass, So you're going to have a low hemoglobin and hematocrit on blood screening. So if you have less hemoglobin than usual, you're going to have less oxygen than usual going to the tissue. Methemoglobinemia is also another cause. That's when you have oxidizing of iron to a 3+ state. And iron can only bind oxygen. Well, I guess, first of all, quick refresher, hemoglobin molecule, right, has the iron at the center of it, and that's what allows it to bind oxygen. And iron can only bind oxygen in the 2+ state. So if you have anything that causes this oxidation of iron, who remembers oil rig, right? Oxidation is the loss of electrons. When you lose an electron, you're losing something negative, so you become more positive. So the oxidation of iron into a 3+ state means that the hemoglobin is doing a much worse job of binding oxygen, and you get tissue hypoxia. And then carbon monoxide poisoning we already talked about. That's when carbon monoxide binds up the hemoglobin instead of oxygen, and as you can imagine, you will get decreased tissue perfusion. So just remember, think of hypoxia at the tissue or organ level. Okay, so why is hypoxia bad? And to answer it in a simple term, there's simple way, the most simple way, it's all about ATP. Okay, and probably some type of a test question about this. Because O2 is the final electron acceptor, so we need it in our electron transport chain to make ATP, right? Oxidative phosphorylation. And when you have decreased ATP, you first get reversible cellular injury, and the big hallmark of that is cellular swelling, and I'll explain that here in a second. You see other things, but that's the easiest thing to remember. And eventually you get irreversible cellular injury and death. And the hallmark of that is membrane damage. And you could eventually get apoptosis, which is programmed cell death in response to the membrane damage. Okay, so let's think about mechanistic stuff here. If we have decreased ATP, this is bring back some chapter 1 stuff to tie in. Remember, this sodium-potassium pump is reliant on ATP. So if you have less ATP, this is going to be knocked out. Now all of a sudden, this sodium cannot be brought out of the cell. So sodium is going to increase inside the cell. Now what follows that? Water. And that's one of the main reasons the first thing you see is cellular swelling. And additionally, there's going to be, if you start to have membrane damage, that swelling is only going to get worse because you lose the barrier to the concentration gradient. So, even more sodium's going to come in. And probably the most important ion for irreversible injury is calcium. So calcium inside the cell is kept very, very low for a reason, and that is because if any free calcium comes in, it's a enzyme activator. So what happens is calcium comes in and activates all these enzymes that results in auto-digestion of the cell. So the cell basically will kind of kill itself via these lytic enzymes that break everything up. And remember, your organelles are inside the cell are also surrounded by a membrane. So if those get damaged, then any lytic enzyme or autodigestive enzyme can leak out into the cytosol, and then there's a bunch of calcium in the cytosol, and that just results in this soup of enzymatic reactions that cause irreversible injury. What else do I want to say? Oh, another thing you'll see here, acidosis. You'll also see acidosis when you get hypoxia. So some common causes of hypoxia to keep in mind. That makes sense, right? Decreased cardiac output. Hypoxemia, we'll get to that. Decreased PO2 causes decreased percent saturation, and that will eventually cause tissue hypoxia. And I talked about these, right? Anemia, carbon monoxide. Cyanide poisoning is a, I forget if it's an uncoupling agent, but it does, oh maybe it knocks out cytochrome C in the electron transport chain. But basically, big picture wise, it impairs oxidative phosphorylation. And hopefully you guys should know this already, but what does the kidney release in response to hypoxia? And the kidney is very, very, very sensitive to decreased tissue perfusion, aka hypoxia. So the series of reactions include an upregulation of an transcription factor, and transcription factors act on DNA to cause increased gene expression, and then you get increased synthesis. And erythropoietin is the result, and that goes to the bone marrow. And tells it to ramp up the production of red blood cells. And this is very intuitive, right? You want your kidney to do this. If it senses low oxygen, you want it to send a hormone in the form of EPO to the bone marrow to ramp up production of red blood cells. And this is what, who was it? There's like Lance Armstrong was famous for. He would actually carry around, I think he would like, him or his trainer would give himself like blood transfusions, and the fresh blood would contain EPO. And then also, you can also just inject a pure hormone, I think. But when you hear blood doping, that's what that is. And now on to hypoxemia. So kind of shift your gears now. We're no longer at the tissue level. Now we're at the level of the arteries. So these are the definitions I talked about: less than 60, less than 90, and the definite low partial pressure of oxygen in the blood. So I want to talk a little bit about what this is. This P small AO2 is determined by. So the first thing to keep in mind is, what percent oxygen are we breathing? So the fraction of inspired oxygen is part of an equation. So this should actually be PiO2. PiO2 is kind of more of a determinant. They both determine the eventual alveolar PO2, but so the alveolar gas equation determines the amount of oxygen that is actually going to reach the alveoli, and it's determined by the fraction of inspired air, which is F, and times the atmospheric pressure minus the pressure of water vapor. And remember, in like high altitude situations, the atmospheric pressure decreases, so you get decreased PiO2. So the way to think about this is if anything to the left in this flow of things, PiO2 or FiO2 or P big AO2, if any of those things are decreased, you're going to get decreased P small AO2 and decreased saturation. And if you have, if you had high altitude, that can cause hypoxemia because this is decreased. If you have a ventilation perfusion mismatch, that can decrease the alveolar PaO2. And we'll go into some other examples of causes of hypoxemia, but those are just a couple. This is a good just flow of things to keep in mind. The atmospheric pressure and the pressure of inspired oxygen determines the pressure of alveolar oxygen, which determines the partial pressure of arterial oxygen, which determines the saturation of oxygen. Okay, so these are the 5 big causes of hypoxemia, and you just gotta know these, as well as the causes of hypoxia. Hypoventilation, high altitude, diffusion defects, VQ mismatch, and right to left shunting. So just to go back to this, which one of these would hypoventilation decrease? P big A, O2, because you're breathing less, you're bringing less oxygen to the alveoli. So you decrease that, everything to the right will also decrease. Hopefully that makes sense. And these two, as you'll see in the next slide, you will actually see a normal AA gradient, and that's very high yield right here. And all the other ones you see increase AA gradient. Anything else I want to say? I think that's it. Okay, so practice question to sum it up. Hopefully this should be fresh in your mind. Which of the following is not a cause of hypoxemia? Okay, so first, what is hypoxemia? Remember, it's PaO2 or P small AO2 less than 60 and percent saturation less than 90%. So you should be thinking any VQ mismatch can potentially cause hypoxemia. It doesn't always cause hypoxemia. So just read this question like, what is a possible cause of hypoxemia? So A and B are both alterations in ventilation perfusion ratio. C is a diffusion impairment in the alveolar wall. Think something like fibrosis, right? Interstitial fibrosis. Any fluid buildup in the alveolar interface with the pulmonary capillary endothelium will cause a diffusion impairment. So that will definitely cause hypoxemia, so that's not right. And decreased PiO2, remember, leads to decreased P alveolar O2, which leads to decreased arterial O2, which leads to decreased saturation O2. So the only answer left is vigorous exercise. We can all be glad that doesn't cause hypoxemia. And remember, exercise actually brings the VQ ratio close to 1, which is perfect. I'm just going to power through and talk about hypoxic vasoconstriction in this lecture as well, since it's hypoxia. Okay, so response to hypoxia in most tissues of the body, the response is vasodilation. And that is kind of intuitive, right? Because if we have a random organ and it's receiving less oxygen, the response should be to vasodilate the arteries that are feeding the organ, because that will potentially allow for more oxygen. So that's always been intuitive to me, but that's also a reason why hypoxic vasoconstriction is a very popular test question, because it's a little bit counterintuitive, and it is entirely unique to the lungs. Okay, so probably a test question about this concept. So in the presence of alveolar hypoxia, and this is, remember, this is like the, how do I want to say this? Well, I'll just go through this flow, and hopefully it'll make sense. So there is a situation, we have low oxygen levels in the arteries that feed the lungs, the alveoli. And what happens in response is vasoconstriction of the small pulmonary arteries. Remember, the arterioles have a lot of smooth muscle, so that's going to allow for that vasoconstriction effect. You get a decrease in size. And remember Poiseuille's law or whatever. Decrease in size means decrease in radius, which means increase in resistance. Why? So the idea here is to, this is just an intrinsic mechanism in our lungs. It's kind of smart. So the idea is to redirect blood flow from the bad, the alveoli that have low oxygen levels supplying them, to good, well-ventilated alveoli. And you get more perfusion to the good areas, less perfusion to the bad areas, and theoretically that should help maintain the VQ ratio. And the Wikipedia reading on this is pretty short and really does a really good job of summing it up. And then if you're still having trouble, I'd recommend, it's about a 9-minute Khan Academy video. Okay, which of the following will cause the greatest increase in pulmonary arterial pressure? A lot of these practice questions I just copy and paste from this website, and for some reason they love like animals, like dogs and cows, things like that. Okay, so let's go through and eliminate some answers. An increase in blood flow, surprisingly, does not increase the pressure. And remember, that's a good thing, because it's like during exercise, for instance, we increase heart rate. You're increasing the cardiac output of both ventricles, but of the right ventricle in this case. So you are increasing the pulmonary blood flow during exercise. But it's a very good thing we don't get an increase in pulmonary arterial pressure from that, because the pressure gradient is there so that blood can flow from the heart to the lungs. Right? I hope that makes sense. Heart sends deoxygenated blood to the lungs, so we want higher pressure in the right ventricle relative to the pulmonary artery, right? Because the change in pressure determines how efficient the flow happens. Okay. Stimulation of the vagus nerve. Oh, these animals crack me up. Stimulation of the vagus nerve. Nope. Inhalation of tidal volume. Nope. Just normal tidal volume. But if you expose of a cow to hypoxia, you get vasoconstriction And remember, the mechanism of that is smooth muscle contraction in the pulmonary arterioles. And that causes decrease in radius, which causes an increase in resistance of the vasculature, which causes increase in pressure. And these are just some pictures to help visualize what's going on. This is normal. These are the alveolar air sacs. We have our pulmonary artery blood flow coming in, getting oxygenated, then leaving in the pulmonary vein. Here is the conducting zone of the lungs, or I guess by now it'd be respiratory zone, but regardless, breathing air in there. So now what happens is, if this alveoli is like poorly perfused with blood or poorly ventilated, the lungs use this intrinsic message to shunt blood away from this green alveoli here to bring more blood to the good, well ventilated, well perfused alveoli to maintain ventilation perfusion. Okay, we are going to talk about the AA gradient next time.